Okay, welcome everybody coming to the sixth Clinical Ethics Grand Round. Please take a seat. Okay, I'm CKD, the chairman of the NTEC Clinical Ethics Committee, and this is a joint activity with the School of Bioethics led by Professor Kamter. And so this is the sixth Grand Round. We are having it every 3 months. And some of you might have come to our Grand Round. Oh, be careful, be careful. not too excited at this moment. You will be something more exciting in the coming minutes to be presented by Professor Kamter. We will be continuing these Grand Rounds every 3 months. And so I hope that this will be continuing in the coming years, because this is required by both the hospital authority and also the medical council for the ethics teaching. I'm so glad that we have been holding this for 6 times. And since this is my last time as the chairman of this Clinical Ethics Committee, I'm so glad that I will be passing my chair to Professor Simon Chan, who will be taking up in future. So he will be doing more education activities for the staff and also helping in the education for the students as well. So I will pass it to Professor Kamter for this very interesting case discussion today.
So as people are coming in, I thought I'll begin the session with something very provocative. Actually, the matter today evolves around ultra-major surgery without having cross-match blood. Now, I know many of you have probably just got your exposure to clinical medicine and you have not seen what happens when real blood starts flowing in the operating room. But actually planning and going ahead with ultra-major surgery without cross-match blood is like jumping from a plane without parachute. Actually, it's not jumping. It's pushing somebody from the patient out of the plane without a parachute. And therefore, I thought, I don't know how many of you have seen this video.
Gotcha. Lights are on. Jumpers are climbing. Doors open. Here we go. Jumpers are away. Jumpers are away.
If you've seen this video, put your hands up. Alex, what's happening? It's so slow.
Now he's practicing the flip. That's how he'll have to land. He'll have to land on his back.
That's why. No time.
And he'll have to land on his back. There goes the oxygen mask. Now at 12,000 feet, he'll hear a beep in his helmet. That will tell him he's halfway home.
So this guy's flying without a parachute, and now he's taken off his oxygen mask. The video is incredible, but our computer technology has failed us.
Momentarily, we'll see his jump team pull their chutes, and that means Luke is all alone for the rest of the way. At 6,000 feet, he'll get another beep in his helmet. There goes the chutes. Luke is on his own. And the crowd on the ground looking up, they have a visual on him right now. He's in. And he's kicking and moving. From here, it looked perfect. You just witnessed history being made. Absolutely amazing. Now we want to wait for our medical staff to check him out and give us the official okay. The trap is being lowered. This looks like a win all the way. The rest of this team hits the floor. History made as he hugs his wife.
Actually fell in a net, so to jump from 25,000 feet and fall in a net is incredible. But that is almost, it's history making, it's unheard of. But trying to do major surgery without cross-match blood is almost like jumping out of a plane without a parachute. Just because it can be done doesn't mean we should do it all the time. And therefore, I think that's an important message for us. So today's ethics grand round concerns a teenager who happens to be part of a religious denomination, the Jehovah's Witnesses. And the issue concerns whether to transfuse or not, because transfusion is against their beliefs. I'm going to chair this session, and Dr. W.H. Koch has kindly agreed to present. And I also must thank him and Dr. Bobby for giving us the opportunity to discuss and critique this case and the way things have been managed. On the panel, we have Dr. Simon Chan, we have Bobby we have Dr. M.K. Singh from Pediatrics, and we have Alessandro Lowe, who's our expert legal advisor. I think maybe some of you have attended this type of ethics round. I think the format is standard. We must understand what are the relevant facts, and those are going to be presented. Try to understand what are the ethical questions raised. Who will be affected by the way the question gets resolved? In fact, the way you ask the question also determines that. What ethical principles will govern our decision? And then we will discuss the final resolution of the case. Now, all of you are expected to participate. In fact, a lot of preparation goes in the making of these cases, right from the scheduling to arranging the expert panel, discussing them. So this is all for your benefit. We want you to be able to discuss cases and manage them in the right format and in the correct principles when you become practicing physicians or surgeons or doctors. So to participate, all of you must vote. All of you must make a commitment. You must commit, because I think that will give you the confidence of whether your thinking was correct or otherwise. However, you must not be influenced by anybody. Try and make an unbiased choice. The whole idea is to critique ideas, not people. It's the idea or the approach that needs to be critiqued, not the individual who made that decision. Also remember that the majority choice may not be the correct one. So don't be afraid to put up your green or red card if you disagree, or it doesn't matter. Your thinking is very important. And I think your involvement is the only way you will learn, because in ethics, nothing is right. Often you have to make the better of the wrong choices available. And I think that's one of the most difficult things to teach. It's impossible to teach, but we can showcase some of our cases, some of our mistakes, some of the ways in which maybe you might think a better approach could have been resolved. Again, I know so far we may not have covered all of ethics in our curriculum, but certainly things are improving. I think it is well accepted that there are 4 key principles defining medical ethics. The 4 principles are very widely used and accepted. The first is autonomy. That's the capacity for self-determination. The second is beneficence, acting in the patient's interest and doing good. The third is centered on preventing harm or non-maleficence. And fourth is justice and fairness for all. Apart from these 4 principles, there are other rather universal ways in which ethical behavior is appraised. And I'm going to come to that as well, because one of the central themes in medical practice is the conflict between what the doctor wants and what the patient wants. Because what the doctor thinks is absolutely correct is a very paternalistic attitude. Well, let me tell you, we are all like that. We still are in many ways. And I think a free agent, a moral free agent, must have the capacity to make his own choice, however, and that is autonomy. So I think the tension very much in medical practice is the conflict between these two. But there is a moral, ethical, behavioral framework in which there are 7 elements that are looked at. The first is harm. Much of medical practice, the underlying premise is the opposite of harm. That's care and doing good. Fairness, liberty, authority, loyalty, sanctity of life and of personhood, and truthfulness. So these are very, very simple but key elements in understanding ethical behavior across professions, not only medicine. And if you keep these 2, the 4 principles, and these 7 behavioral anchors or traits or categories, you will be able to make ethical decisions. And with that, and of course, as you become experienced, you will be able to discuss even more. So with that, I'm going to ask Dr. Kwok to start with the presentation. And at certain points, we're going to stop. We open the floor for some Q&A based on some anchor questions. WH, thanks.
Yeah, I'm Dr. Kwok, the consultant anesthetist of the Department of Anesthesia Intensive Care. So basically, this is a case presentation. The patient is a 14 years old, healthy teenager. Before we saw the patient, on the same day, okay, the patient had been attending the orthopedic clinic for congenital scoliosis. Congenital scoliosis means this is not idiopathic scoliosis, which means there's some abnormality of the vertebra. There's a hemivertebra of one of the level have been identified. He did have some symptoms related to lower limb numbness with MRI, require admission to the hospital with the MRI show no acute cord compression. But the symptoms, the numbness, have been attributed to scoliosis, underlying pathology. So on that day, the orthopedic surgeon seen the patient in their clinic. Elective scoliosis surgery has been planned. Some background information was that the parent was divorced, and her guardian is her mom. Okay. And when one of the junior orthopedic specialists saw the patient, and there's some discussion because originally the mother and the patient have some concept that this surgery most likely do not require blood transfusion. Where this concept come from? We guess this is come from previous visit from the orthopedic clinic. Maybe someone have said something before they know all the surgical planning. Maybe they think it's not likely to need blood transfusion, and that's why when the patient arrived at pre-op anesthetic clinic, that one of my MO saw the patient, they immediately call me and say, what should we do? And also the orthopedic. And on that day, the orthopedic specialist saw the patient, and now we explain that scoliosis surgery very high likely require blood transfusion. And obviously the mom wouldn't want blood transfusion, and the approach by that specialist was that, okay, then you sign a refusal form for me, please. Now, only the parent signed the refusal form. The doctor never signed on the same form, okay? Okay, and this form is described as life and death contract, 生死狀. That means, I think the meaning is that it's an intimidation way of telling the patient that, okay, if you don't want blood transfusion, if you die, don't blame me, something like that. I guess the underlying meaning is. This provoked emotional distress, and the patient on that day cries, okay, a lot of bursts into tears. Okay. In the afternoon, he was seen by our anesthetic clinic. So initially, a resident and a specialist, okay, saw the patient, and then I was called to see the patient too because it seemed to be a complicated case. And then I need to talk to the PRO, read the X-ray guideline, and then in the corridor, grab someone, okay, what should we do, okay, before I saw the patient, of course. Okay. This is not an everyday patient, but the approach was non-confrontational, try to find the fact, and we try to explain the thing honestly and try to reach common goal and solution. And from the mother, they have a very strong religious belief. She don't want any blood transfusion. And she give a fake documentation to tell from the church to tell us how to do bloodless surgery, etc. And we politely get the file and put on our PhD cabinet, okay? And mother claimed that her child is mature, has the same strong faith, religious faith, and the same wishes of no blood transfusion. Please respect her decision. Somehow they say they accept intra-op cell saver, but do not accept pre-op autologous blood donation. That means the patient donate the blood herself to save in our blood bank, but this is not acceptable. Okay, this is normal. This is quite normal for Jehovah Witness not to accept autologous blood. Okay, because they view that when the blood leaves their system. If they are for storage and transfuse, this is not acceptable. And then there's another person in the clinic, is a friend, described as a friend, but we feel that this must be the church elder. Okay, so ask us to read the church document, and they tell us a successful story in Hong Kong, oversee how to do bloodless surgery. There's a drug called erythropoietin we can give to build the hemoglobin, etc., etc. And then please respect their faith. Again, he iterates they accept interrupt cell saver, but do not accept pre-op donation. At that point, our explanation is that there's high possibility of blood transfusion, given the fact that the surgery is ultra-major. And it's a surgery for congenital, not idiopathic scoliosis. That usually mean more bleeding, more complicated. We will certainly use cell saver, which is part of our normal, regular way, okay? And we have no experience of erythropoietin. We have explained all this. But this is the fact, okay? We're trying to at least lay out a common fact. And this is subsequently, yesterday, a few days ago, I do a mini audit of our scoliosis surgery. I didn't bother to do all the complicated statistics, but the transfusion incidence of doing scoliosis surgery is 78% of the time. We need at least 1 unit of blood or 2 units of blood or some FFP or some platelet, okay? Some blood product requirement, okay? Which is approximately, this is what we mean high risk of blood transfusion. And on that day, we have only half an hour to read all the literature, okay? And at that point, our concept was that we will give blood to the child or minor to save life, even if the parent or the patient has signed a refusal form prior to surgery in life-saving situation. In this case, because this is an elective surgery, not to save life, not for cancer, etc., we feel that if no consent for blood transfusion was available, then no anesthesia can be offered. And this was explained to the patient, because that was our concept at the moment. And hypothetically, if we proceed to surgery with blood refusal form signed, we may still give blood for life-saving indication during surgery with or without court consent. So that's what made me a bit confused. Why, if I allow them to sign the blood transfusion form, a refusal form, but during surgery, I may give blood with court order or with CT Hong permission, okay, I give blood, okay. But I'm very confused myself. So that's why we feel that we cannot offer surgery. So we lay out the fact and we try not to be antagonistic, okay. And also we give the family time to reach a favorable consensus, favorable for us, okay, at least, okay. Okay.
Okay, so far we have a Jehovah's Witness, very strong religious beliefs, elective surgery, clear evidence that this patient is going to require blood because of the history of blood transfusion with major surgery. So I think the anesthetist dilemma is pretty well appreciated, that you're going to need surgery. If you sign a consent form that you don't want and you agree, we are not going to give you blood transfusion. But in the case of life-threatening situation, the anesthetist thinks one can override that. So here is a dichotomy and a conflicting issue here. So I think the key issue definitely is a technical one. We're going to bypass this later. First, the anesthetist's view is there's ultra-major surgery, risk of bleeding. The surgeon's view is ultra-major surgery. We've jumped from the plane before. We may avoid transfusion, and it's an acceptable risk. So I think the tension between the anesthetist and surgeon, we're going to explore that last, because I think that's the least of the problems. So, key ethical issues. First, in view of a strong faith-based family, is the parent's decision binding on their child? That's the first one. Those who agree, put up a green. Those who disagree, put up a red card. Okay, first, let's vote. Okay, so the parent's decision is not binding, means red. Very good. I still see some very obedient people, so I may ask 1 or 2 green card holders to give us please don't be intimidated or afraid, or it's absolutely reasonable to go against the majority. It's, so why any of the green card holders want to say, why should the parents' decision be binding on their child? Anybody? Michael, did you put up a green card? Oh, you put it. Okay, let's move on. Second, is there an ethical need to seek a minor's view, particularly on matters that touch life and death issue? Okay, I still see a red card. One. Can I have a quick view why a minor's view should not be? We can have a mic. Anybody with a red card? I just saw a red card. So anybody wants to explain why the minor's view should not be sought? Anyway, the majority agree with the fact that in the view of a strong faith-based family, the parents' decision need not be binding, and therefore, particularly in matters that touch life and death, we need to seek the minor's view independently of the parents. Now, we also need our legal friends to help us. Is there a legal need to seek minor's view, particularly if treatments and interventions are likely to result in harm? And I'm going to ask Alessandra to comment. At what age is mental capacity, particularly to refuse interventions or actions such as withholding blood that may cause harm, considered legally valid? Is that clear? I want to know what age is mental capacity to refuse legally valid. So I'm going to ask the two experts to comment first. The first one is Dr. Singh, who's going to, you can comment on the first two in any order, and Alexandra, you can comment on all four. So Singh. And please feel free to stop and challenge your experts. They are here to satisfy your concerns.
I was asked to see this patient. That patient was referred to me. Somebody called me, the anesthetist called me, and I tried to arrange in clinics to see this patient. I don't know why me. Yeah, there are several hematologists here. But probably in the past, I had a patient with lymphoma, about 6 years old girl. Parents also from this background, family. And that time I had a long discussion with the church elder, the parents, both father and mother, and also the child too, yeah. Because we need to start chemotherapy. Chemotherapy will suppress the bone marrow. And then, yeah, there are risks of bleeding and risk of the need of platelet transfusion or blood transfusion. So this is my second time, yeah. So before that, I think, why? Okay, yeah. And then I asked the mother to bring the child to the clinics. But when I arrived, the mother came alone. And then I asked her, it's better to talk with the patients too. Yeah, because I know it's 14 years old girl. She may be able to understand, yeah. Then the mother asked the child to come because the child went to school in in Shatin. That's why the patient was brought to the hospital to see me, yeah, together. So when I saw them, before they came into the consultation room, the mother and the child were sitting on the two ends of a bench, back facing each other. That means that they were not looking to each other. So I know there's something there, there's a tension between the mother and the patient. And I asked them, invite them to come in, and I also see they didn't look at each other. Yeah. So then I start talking with them and I try to explain the same as the orthopedic surgeon, yeah, the risk of bleeding. It's a very vascular surgery. The patient likely to receive blood transfusion, require blood transfusion. And the mother told me that she's trying to find a surgeon who can promise her that 100% chance that no need of blood transfusion. Oh, then I say I couldn't find, I cannot believe that somebody can do such a bloodless operation, such a safe operation. Yeah. She want to delay the operation. She want to find. Yeah. She say she has friends who had cardiac operation without blood transfusion. This is what she believe. And then I say, oh, you have the right to seek an opinion. I respect that. Yeah. I can refer them to Queen Mary, Queen Elizabeth, or other HA hospital. Okay, because I believe HA hospital is safer. We have a system to support it. Okay, whether you agree with me or not, yeah. Okay, but the child immediately told me that she has been followed up in the orthopedic clinic since primary 3. Now she is already 14. It's been a long time. She doesn't want to postpone the operation. She wants to have operation now. Okay, then what in my mind, yeah, I know there's a child protection order, but I don't want to bring it out, this issue, so early, because it will break our relationship, yeah, and antagonize the mother. But I was trying to let her know that as a medical doctor or health professional, we don't want to cause harm to the patient. Especially in this situation, the patient may lose her life. Okay? I don't want to delay the decision up to the point that when there's severe bleeding, then we do something against the will. Yeah. And then in my mind, I also try to address the religious issue. Yeah. What do you think, yeah, if we, doctor, actively make the decision to transfuse blood to the patient, and the patient is simply passively receive the blood transfusion? It's not you. You didn't commit the crime. We did. Yes. Then I asked in the past, in the first patient with lymphoma to the elder of the church, so what do you think? Yeah, we did something against your will. In our mind, we tried to save your life. Yeah, we didn't want to do something bad for you. But if we transfuse the patient, this is a child, yeah, against your will, what do you think about it? Then the church elder told me that then they will consider that as a sin. Okay, the sin. Then I follow up this question. I asked, will the child go to heaven? Right? For a Christian or Jehovah Witness, we believe in God. Then most important issue, whether the child can go to heaven or not. Right? The elder told me they think something dirty happened to me or contaminated. The patient can go to heaven. Yeah, that's what I heard. I didn't read all the document they gave it to me. Yeah, huge pile. But for me, for me as a doctor, I cannot accept the idea not if I transfuse, can save the patient's life. If I do not transfuse, the patient dies in front of us. I think most of us will think in this mind. Okay, so then I will talk to in the church elder. I told him, then you blame me. Then I committed sin. You didn't. Okay. In the end, in the first patient, the father agreed to sign the consent. Okay. And for this one, yeah, the child when I saw her face, she was very happy too. So I think it's a relief to her that she think, oh, you, doctor, you make the decision, not me. Okay, not her. It's a great relief to the mother. Okay, so that's what happened in the clinics. That's what the communication, exactly what happened. And the mother then, in such a way, I will sign the consent, but reluctantly. That's what she said to me. Okay.
I think that's a very good and succinct explanation. I think one should not underestimate the distress that possible excommunication or possible violation of very strong faith-based families can have on the individual. It's extremely distressing, and it has a very powerful influence. So I think as much as we completely disregard some strange faiths, there are people who believe them, and they have their own choice. So I think that's a difficult decision for us. But I think you explained very well. Now I would like to have Alexandra's legal view on, and I think I also appreciate his first statement that he tried not to be antagonist, and I also take your point. That's very important. You know, it's easy to just go and take a court order, but that's going to destroy both the doctor-patient relationship and probably the relationship within family members. And I think that should be the last step. So I really appreciate that. But let's have the legal view as well.
Yeah, I appreciate the same approach as well. But because this is such a difficult question, I prepared some slides in advance so I could hide behind my slides.
Just speak a bit loudly.
Right. Right. I'm just going to go through very briefly about the legal concepts that affect this discussion. While you may not agree with me, I think lawyers are actually reasonable people, and so are judges. And so I think as to where you draw the line in this case, I think it is a shifting line because it's such a difficult decision that sometimes you cannot really find black and white rules regarding what you should do, and it's shades of gray. But if we talk about these issues of competence, giving of consent, it's all related to the issue of autonomy, patient autonomy, as we read in the 4 principles. And the question we need to ask ourselves is how important is autonomy? It's just one of 4 principles, and it needs to be balanced against the other principles, like Professor Kumte's slides tell us at the beginning. But just very briefly, on the question of competence, we should understand that competency has traditionally been associated with the age. And the law presumes that adults are competent, whereas children are not. And this is related to the development stage of childhood, as reflected in both their cognitive abilities as well as their life experiences. So the age of majority decided in most countries, including Hong Kong, is 18 years old. But some experiments actually show that adolescents generally do not possess the capacity to appreciate the long-term consequences of their choices until the age is 21. That's why in the past, some of the age of autonomy is 21 years old. But I think there's general consensus that normally children under 12 have no formal right to be involved in the informed consent process. In this case, the child is about 16 years old, and in 14 years old, and in law, once the child reached 15, 16 years old, there is a very well-known case called Gillick and West Norfolk Hospital Authority, and we call this Gillick competence. That means that while the person has not attained a majority and can make decisions for themselves, because they have sufficient intelligence at 15, 16 to enable full understanding of what is explained and proposed in the medical treatment, they should be considered competent to give consent as well. Now, in the UK, there is also a statute about this, but in Hong Kong, we do not have that. So we have to ask ourselves, by drawing a line of a child at a certain age, whether they can give consent instead of their parents, whether this is arbitrary, and whether this should be taken on a case-by-case basis. And this really answers the question, one of the questions posed, which is, should we take into account the views of the minors when deciding cases, right? Okay, so these rules are meant to ensure justice and to protect those subjects requiring protection. Now, the question is, while they are aimed at protecting those subjects, can injustices sometimes occur because of those rules? Now, we looked at some of the case law, and it seems like juridic competence allows a minor person to give consent to certain medical treatment, maybe research, and so on. But when it comes to giving them the right to refuse treatment, then is it the same thing? Do we apply the same principles? My belief is that they are not the same thing. Once it comes to refusal of treatment, I think the court would be quite prepared to shift the line either up or down to reflect a more pro-life approach. And I think one also needs to look at some of the other factors, which is whether the procedure would be irreversible and whether there's the gravity of the consequences. If the consequences would be the loss of life, then I think the court would be quite prepared to, I wouldn't say bend the rules, but I think to listen to both sides of the story and listen to the views of the not only the minors, but their parents, and especially the attending doctors. If we look at the case law, we see that the court has somehow been prepared to overrule the decision of children and sometimes even parents in refusing treatment. All of these cases show that the court have overruled the patient's autonomy. And the last three cases are all about Jehovah Witnesses. At point D, which I have pointed out, as to the question of whether the parents' right can overrule the child's wishes to stay alive by pursuing some kind of treatment which are life-sustaining, I think the court would look at not the parents' right to overrule the child's decision, but rather the parents' responsibility to ensure the child's best interest. And last but not least, somebody mentioned the Child Protection Order. There are some statutory provisions under the Child Ordinance as well as the Mental Health Ordinance to enable court orders to be obtained in certain cases. But I would also like to make the point here that we are talking about the decision of minors, which are about 14, 15, 16 years old. But 2 years later, they become adults, and they would then have the right to refuse treatment. So in terms of difficult cases like Jehovah Witnesses, where it's now widely known that they refuse blood transfusion, and some of which would cause threats to life, it may be imperative on the medical field to actually come up with some principles to deal with these cases, and taking into account the church documents. I think I really admire Dr. Shing for actually going through the church documents and trying to find out how to resolve the difficulty to address their concerns, not just imposing one's own views over the patient's views. I think it applies not just to Jehovah Witnesses, which are so common, but also other beliefs and approaches to life. I think I'll just stop there, and we'll continue.
Okay, so that is quite reassuring for the time being. So as we understand, the courts will take a pro-life approach, and if the child is refusing a treatment that is beneficial, would certainly override the child's wish for autonomy. On the other hand, the courts might also consider the child's view, particularly if a treatment the child doesn't want is going to result in harm. And I think CK might remember we had a child, a parent insisted on a quick amputation for an osteosarcoma because she had the belief that an early amputation would save this child's life, and the child was morbidly terrified. Of course, it took a few sessions of counseling, but I think it's not unreasonable to see some parents expecting some drastic treatments, which obviously a child wouldn't want to have. So I think, but I appreciate the pro-life approach.